I'd like to welcome you to this edition of the PRS Journal Club podcast with your hosts, Dr. Sammy, Sinno, Amanda Silva, and Raj Sawh-Martinez. Enjoy.
Hi, everybody, and welcome to the November edition of the PRS Journal Club podcast. I'm Sammy Sinno, and joined, as always, by my co-resident ambassadors, Raj Sawh-Martinez and Amanda Silva. This month, we are very fortunate to have Dr. Bill Adams from Texas, also associate editor of the Journal, here with us to discuss the articles. Dr. Adams, thanks for joining us.
Absolutely. Great to be with you guys.
In this podcast, we're going to discuss the article entitled Anaplastic Large Cell Lymphoma in the Plastic Surgery Practice. Has it influenced practice patterns? By Dr. Pittman, Fan, and Rudolph from Georgetown University. Here, the authors notes that while the case reports of ALCL continue to increase, we really haven't changed our practice patterns necessarily. What they did was devise a 19-question survey and send it electronically to U.S. and international board-certified plastic surgeons. And they had a fairly respectable response rate of 13.5%, representing over 1,300 surgeons. And what they noted was that 9.5% of respondents had some personal experience with ALCL in their practice or in a colleague's practice. What they found was that less than a third of surgeons discussed ALCL at the initial consultation, and just over a third even put ALCL on the informed consent. They found that surgeons from France, Germany, and Australia were more likely to include ALCL in their consenting process. And they found that also surgeons that used a higher frequency of textured implants and those that were in academic practice were more likely to discuss ALCL in the preoperative period. Interestingly, they noted that although their response rate was 13.5%, they did have a relatively higher reported frequency of patients that were seen with ALCL in the respondent practices, which is slightly more than what's typically the reported incidence in the literature. They did point out some limitations in their study, including the fact that while it is the average for survey-based questionnaires, 13.5% isn't an overwhelmingly large response rate. And they also noted that there may be some bias in that the surgeons that responded to this questionnaire may have a specific interest in the ALCL or had experience with it. Nevertheless, I thought this was an interesting paper that caught into attention a very important issue, and excited to talk about this with you, Dr. Adams. You've taught all of us, including myself, so much about the process of breast augmentation, and I model a lot of my preoperative discussion over the things that you've taught and spoken about. I'm just curious to see where the ALCL topic fits into your discussion preoperatively, and what are your thoughts, and should we be doing more across the board to educate our patients about this a little bit more prior to surgery and when selecting various devices?
Yeah, I think this is a real interesting article. You know, it's got some things. It's a survey, and surveys obviously have their limitations, but, you know, you shouldn't throw the baby out with the bathwater. It's still good information for us, and I do think that breast implant ALCL is something that it receives, I would say, probably maybe a little bit of a disproportionate amount of discussions and meetings, things, but it is new, and we don't know everything about it. I think the paper is a good one, and it brings up some good discussion points. I thought that the single biggest piece of data from that paper that I found interesting was that they said they only found that even though that people tend to aspirate seromas for the most part when they have a late seroma, only 34% actually send it off for analysis, which the recommendation, you know, is to send a CD30 and an assessment for cytology. And that's been my experience in just hearing about this and learning about this, that people just need to be aware. It's a very treatable entity. I think that ultimately it will become a lymphoproliferative disorder instead of a lymphoma, as it's currently being called. But if it's diagnosed early, it's very treatable. In fact, all the patients I'm aware of that have been diagnosed early have all been cured. So the big thing is that you want to find that out before you go to the operating room. If you have something that's a late seroma and you want to, you know, aspirate fluid and send that off. I mean, did you guys find that interesting? That I was surprised to see that number being as low as it was in the survey.
Yeah, I actually didn't didn't mention that in the review, but that was very interesting to me because we sort of, I think, as residents have a lot of in-service related questions and items to that effect, that if you have a breast aug patient and you have a late seroma, that's sort of the trigger and thing that you're worried about in terms of being ALCL and what to do and send for the appropriate cytology. So I was a little surprised to see that number was relatively low. What about you guys?
Yeah, I agree, especially given that you pointed out with such a low response rate that we potentially had a bias for people who have a special interest in ALCL. So you would hope that maybe, if anything, you would have seen a higher rate of people properly managing these late seromas. So potentially not even an accurate number, maybe even lower number of people are accurately late seromas.
Yeah, no, I totally agree. And I think one of the interesting things is, we citing numbers. When we talk to patients now, what numbers should we be giving them as far as the incidence of this in that adequate consent? And I think there's so much that we think, seemingly, Dr. Adams, I think you're one of the world experts. You certainly help us out here. But I think that some, faculty may have trouble figuring out what are the numbers to quote to tell patients of their risk. And I think we oftentimes may be downplaying maybe ALCL a bit because it is such a rare developing entity. I'm not super surprised that a third of people only are sending the fluid. They may not necessarily be thinking of it when they see the late seroma fluid, even though they should be. And we do have an international survey audience here in this paper, so I wonder how much of an influence that may be playing a role where, in the U.S., we're all very cognizant, have medical legal concerns, and are always sort of thinking ahead of those issues. Maybe in socialized states, it's sort of, if it's not a clinical relevant or clinically apparent issue, maybe they do just send the fluid out and deal with whatever the patient's got going on because it may be an indolent course. So I don't know how much of those two things may be playing a factor in that low number.
I think they definitely do play a factor in it. But I think it's good for the readership of PRS. That's probably one take-home that you take. That if you have a late seroma, you should do an ultrasound before you decide what you're going to do and send that fluid off for cytology and CD30. And I think the last thing, not to belabor it, but you guys already mentioned, I think, whether it's in informed consent, I think ASPS revised their consents to include that. I think it's totally appropriate to have it in there. Certainly it should be in some form of either your informed consent / disclosure or your educational documents that are, reviewed and executed by the patient. We don't know how common this is yet or what the numerators, even denominators on number of breast implants in the world or cases, but certainly it's something that just should be discussed. Not usually, I've never seen or heard of a patient that decided not to have a breast reconstruction or a cosmetic breast implant procedure because somebody brought up ALCL. So it's just being complete.
What numbers do you quote currently, or how do you have your discussions with your patients, Dr. Adams? Do you tell them this is a very rare entity? How do you assess the risk for them?
Yeah, I think it is a very rare entity, but just in Russia, just now we were talking about the exact same question. And because we don't really know the numerator and denominator, it's really hard to quote an honest and knowledgeable incidence of this, particularly also if you're using smooth implants, because as you guys know, thus far there's not been a confirmed smooth implant case. So some surgeons are just using smooth implants, so theoretically their risk would be zero. So, if you're that type of surgeon, that would be maybe something that it maybe doesn't need to be in your informed consent per se, but there are certain types of textures, the more macro textures are the ones that have been had a higher association for sure. But yeah, the numbers and the incidences and risk are very hard. I think it's hard to give an educated number to the patient at this point. And I think as we learn more, it may take a few years to get there. We can hopefully come up with a device-specific risk that we'll be able to share with people so they can use that in informing their patients.
Dr. Adams, you mentioned, smooth versus textured. Do you think that it's reasonable for someone to not mention ALCL in the informed consent for people who are getting a smooth implant and only for textured, or do you think it should just be mentioned to all patients who are undergoing implants for reconstruction or augmentation, or it doesn't need to necessarily be mentioned?
I don't think that there's an exact standard for that. I can tell you what I do in my own clinical practice is that we have this in our educational document, that the patient is really kind of part of the informed consent process, and the patient actually initials the different sections of that. So it does have a little section on breast implant ALCL, and it actually says, right now it says in there that thus far all the cases that are known have been in textured implants. So in patient basically in mine that are smooth implant patients, certainly not a concern of theirs or not a big concern of theirs. So that's how I do it, although, I certainly don't think anybody would be at fault right now. They're just using smooth implants to not necessarily have it in informed consent, because until we have one case, it doesn't seem to be a risk.
Do you think in your practice, since you have such a high volume of breast augmentation, do you think patients, because of the increased propensity with the texturization, and then also I think a lot of people are sort of attacking the anatomic implants in terms of the malrotation potential, and also others saying that there maybe isn't a noticeable difference between round and anatomic aesthetically. Do you think textured implants are struggling a little bit and going forward maybe will be less commonly used?
Well, I do think that some of this that we're talking about has an impact on the use of textured implants for sure, particularly in the United States, which texture's always been in a minority compared to smooth implants. Globally, if you go internationally, it's the exact opposite. I think in the U.S., there will be some decrease in the use of textured implants. That being said, there's clearly cases sometimes when textured implant may be a benefit. And so, at least what we know about breast implant ALCL now is that there seems to be a clear association also with certain types of bacteria and basically contamination in the implant pocket. So I think that the whole kind of 14-point plan that was actually published in PRS a few years ago, just steps you take to minimize contamination, is something you definitely would want to do if you're using a textured implant. But something that will evolve, we'll see. We'll see if there's ultimately much of an impact on people's use of textured implants, both here and globally.
Thank you very much, Dr. Adams. It's great to discuss an article like this that's really revealed something important to all of us with a world expert in breast augmentation. Thanks for joining us.